Okay, good morning. I'm Teruhisa from Osaka, Japan, and actually I'm very glad to have a first meeting of the International SCR Association. Actually, I know in US, many doctors may think about the SCR may be dead already, but actually it's not true. And outside of US, Asian country, Latin America, and Europe still growing. SCR number of SCR is increasing. So it means the SCR works. And why we decide the first place of our meeting in US, because we want to tell the truth. What is the truth regarding SCR to the American doctors? So that's why we decided to the Sonoma, and Paul prepared everything, and I want to say thank you very much, Paul and Paul team. He prepared everything. So, and this morning, we will tell about the SCR principle, and afternoon we can make a kind of a workshop, and we need to show how to harvest fascia, making graft, and actually graft preparation, graft making, very important for this surgery. So that's why this afternoon we will show, and tomorrow we will maybe you can learn what is the truth in the world. So many SCR surgeons in the world coming to the Sonoma, and we discuss together. So maybe you can learn many things. So this morning, here core principle is a summary of fascia SCR so far. Here is a schema. So we put the graft in the joint, and not time the granule first. I usually do the 4 mattress suturing, and then lateral side same as cuff repair, suture blade and major mattress suturing, and important thing the posterior side of suture between the graft and the tendon. So this is the brief, the technical key point. And then you can get a good stability. And this is the patient, 51-year-old female, volleyball player. She cannot elevate arm by herself actively, but possibly she can elevate, and elevation, external rotation very limited. Then we did SCR for this patient. It's a massive tear inside the graft joint, and fix the glenoid and laterally the graft velocity and such the suture between graft and tendon. So afterwards, it looks like after local repair, but that is the fascia graft. And 1 year after surgery, she can elevate arm, actual elevation 180, and no shoulder pain, return to volleyball. And now 7 years, she can elevate arm still very well, and a good external rotation, and even abducted external rotation, very good. And still she is doing the volleyball. She's now 58 years old, but she's very active now. And not only her, actually most of the cases, they return to the sports. And also I want to show the 10-year, after issue, is a 10-year follow-up. We just published 2024. This is a really first case of my case of the SCR 48 patient. Actually, 48 patients and 50 shoulders, but unfortunately, 5 died, 5 moved to had a health problem to refuse to participate. So the 34 patients were enrolled in this study, and of course, we did the fascia SCR for the older patient. And here's the result: graft survival rate. The 3 months, we found that 2 patients had graft tear, and 2 years, 1 more patient graft tear, 5 years, 1 more patient. And 5 to 10 years, no graft tear. So survival rate 89% at 10 years after surgery. But this is a really fast cases. So if I do this study now, maybe 10 years later, maybe better healing rate, because at that time we did not find the proper size of graft. So sometimes they're very thin, sometimes very short. But that's why still around 10% graft tear, but now less graft tear rate. So maybe if I do this longer follow-up study, maybe better result. But this is the real first 50 cases. And active shoulder elevation, 1 year after surgery increased from 89 to 149 degree, and about 1 year after surgery, it's not final follow-up. Actually, it's not the final, the maximum elevation. Still increasing. Then 5 years, 162. Actually, 2 years after surgery is around the maximum. Then 2 to 5 years, almost same, and 5 to 10 years, of course, no changing. So even 10 years, good elevation. And this patient, 10 years after surgery, all patients, good elevation, and still, actually, they forgot they did surgery because they feel normal, and they're also without any donor side morbidity. So that's why they forgot they did surgery. And here's the rationale of SCR. Well, SCR improves shoulder function without local repair. Because improves shoulder stability, super stability, then, and also decrease the pain. Then improves deltoid function. Then using the deltoid muscle, they can elevate arm very well. And also we make a side suturing and the posterior side, and also subscapularis repairing. So they increase tension, subscapularis and infrasternal tendon. So restore force couple. That's why the shoulder function improved. And then, but I think the most important factors, the super stability, improved shoulder stability, the important factor to get a good function after surgery. So now I'm telling about my biomechanical studies regarding the super stability. So this is the first biomechanical study for me. They are using cadaveric shoulders with Professor Taikyo Lee's lab. And this is the first result. We compare the intact tendon and rotator cuff tendon tear model, and tendon patch means the graft attached to the torn tendon, and the supercuff reconstruction. Then after rotator cuff tear model created, supertranslation of course increase, and tendon patch decrease but still higher than intact, so it means the partial restoration, but supercuff reconstruction almost completely the normal level. And this is the second biomechanical study. We investigated the biomechanical effect of thickness and tension of fascia lata. This is the effect of the graft thickness. We compare the intact condition and the tear model, and SCR using 4 mm thickness of the fascia lata, and SCR using 8 mm thickness fascia lata. And here's the result, effect of graft thickness. And the left graph shows the subacromial contact pressure. Of course, after cuff tear model created, increase, then even the 4 mm, 8 mm, any graft between the humeral head and humeral head, we inserted, contact pressure normalized. So the thickness doesn't matter regarding contact pressure, but supertranslation different. So the 4 mm SCR decrease supertranslation, but still higher than intact. But 8 mm almost same as the intact level. So from this study, we found the 8 mm is the best thickness of the SCR. 4 mm is too thin. And another study is the cuff thread continuity, like a sighted suture between the graft and tendon. So we compared the 5 conditions: intact, tear model, and without sighted suture. Actually, only the fixed medial and lateral. And next year, only the posterior sighted suture and anterior posterior both sighted suturing. Then here's the result again. The subacromial contact pressure. Actually, if I put something between the humeral head of acromial and humeral head, the contact pressure normalized, but supertranslation different. So no sighted suture, decrease supertranslation, but still higher than intact, and actually no significant difference because not consistent outcome. So maybe I can show this next slide. But a posterior sighted suture, almost same as the intact level, and the anterior posterior sized suture really decrease supertranslation more than intact. So at least we recommend posterior sized suture together intact level of supertranslation. So here is why we need to make such a suture for the SCR. This is without such a suture. During the rotation, it's a human head sublux. Yeah, it's now sublux. Again, you can see the external rotation, now internal rotation, it's a sublux. So so the anterior posterior stability is not normal. So that's why the moving too much. But if you make such a suture posterior side, very stable. So that's why I recommend such a suture posterior side, graft and tendon. And also next study, we compare the fascia lata graft and the dermal allograft. So this is the four condition, intact and cavity model, and SCR using the fascia lata allograft and also the dermal allograft. So this contact pressure, it's again the cavity model increase, then even fascia lata or also flex decrease to the intact level. Again, the even thin or the elastic graft or any graft, even spacer, you put something in the between the acromion and humeral head, contact pressure decrease. But the supertranslation different. The increase the supertranslation after rotator cavity model created red bar, but fascia lata SCR decreased. Actually, this study is less than intact. But arthroflex decreased, but still higher than intact at the 0 and 30 degree abduction. So that's why the arthroflex SCR is a less result, the worse result than the fascia lata SCR. And also I want to show these pictures. It's a left side the fascia lata graft and right side dermal the graft. After range of motion measurements, just we measure the external rotation, internal rotation measurement. Of course, the fascia lata graft did not change the size, but dermal the graft already 15% elongation after external rotation, internal rotation measurement. So that's why the fascia dermal SCR did not normalize the supertranslation to the intact level. So now we are saying that the fascia lata SCR, dermal SCR are totally different animal, like a tiger and cat. So it looks like similar, but a very different animal. They are, so yeah. So so next I want to tell the technical difficult fascia lata SCR. Actually, it's not. So this Hong Kong doctor, Dr. Lee and Dr. Chan is here there, and yeah, they came to Japan only around 1 week. They saw my surgery. Then they studied the SCR in their country. Then they said, yeah, I just did my 7 SCR. I just used 2.5 hours, very smooth. And Dr. Chan also he did surgery and it's smooth. And patient doing fine. And he sent a movie file of this patient. Yeah, very nice result. So even young surgeon, they can do this surgery. So if you can learn my technique, it's not difficult. And also in USA, how to harvest fascia. Many doctors told me it's hard to harvest fascia in USA, but Paul Lodge, yeah, he did my surgery in USA, and after he learned my technique in Japan during the COVID, then yeah, he emailed me he did completed 50 cases in the last 20 months. It's maybe this email maybe around two years ago. So now he did more cases, I think, and the happiest group of patients. And looking forward to helping other surgeons and the SCR fascia lata in North America and beyond. That's why we founded the international SCR group, and now we are doing the first academic meeting. So again, even for American patient, fascial SCR works if you did similar to our technique. So next, I want to tell what graft is the best. Actually, grafts must be thick and stiff. I always tell to the doctors. And how to make a thick and stiff graft? From my biomechanical study, 6 to 8 mm thickness is the best thickness. So, but the fascia is around 2 or 3 millimeter thickness. So even double layer, it's hard to make 8 millimeter. So we always say the intermuscular septum should be included. It's like a 2 tendon tissue. This is the intermuscular septum. It's connecting the fascia to the femur bone. I want to show the quick movie file. It's the fascia. On the surface of fascia, you can see the intermuscular septum. This is vastus arterialis. Then we take out this 2 tendon tissue, they open, then sandwich. Then we can make a 6 to 8 millimeter thickness of fascia. And medial mattress suturing, very important to make a very stiff graft. So this is our graft. But actually, it's not easy to make the thick and stiff and strong graft for the old patient, because sometimes even we include the intermuscular septum. Some patient very thin intermuscular septum or fascia, so we cannot make a 6 millimeter sometimes. In that case, we need to harvest more fascia, but now we made a suture patch in RCS company. It's a very strong and very stiff, the synthetic patch. So if you sandwich like this, there you can make good graft very consistently. Even maybe the beginners, maybe it's easy to make a very good graft if you use suture patch. So I recommend. So I want to show this is a cadaver. So this suture patch, the sandwich using the very thin fascia. Then we make a hybrid graft. Then we made a SCR using that graft. And now pushing the very big guy in RCX, is Mark Ferguson, to hit the femur head to the acromion, but does not hit. Even he tried to hit the graft, but still space. It means not space effect. It's a tension effect. It's a fascia with suture patch. It's 10 years ago. Then we take out the fascia and the suture patch. Then we check the stiff shoulder or not. If the specimen is stiff, it does not hit the acromion, but after takeout, easy to hit the acromion. So this specimen does not have stiff shoulder. Yeah, so the suture patch is it's very reliable, and it makes a stiffer and very stronger graft. So I want to show our biomechanical study. It's a tensile testing, suture patch augmentation. Now this is a thin fascia. It's an ultimate low to failure for 435 Newton. And this is a suture patch with thin fascia. It's not thick, actually, just only the 4 millimeter thickness, but ultimate load is around the triple of thin fascia. And thick fascia, it's similar to the thin fascia with suture patch. So if you include suture patch, even thin fascia, you can make a very strong graft. And also stiffness. The thin fascia 51 Newton per millimeter, and suture patch and thin fascia 85 Newton per millimeter. So 1.6 times of the thin fascia, and it's higher than thick fascia. So if you sandwich suture patch, stiffness increase very well. And also we check the biomechanical testing of the suture patch augmentation by comparing intact tendon, the rotator cuff big tear model, and the thin fascia lata SCR, and SCR using thin fascia lata plus suture patch. So 4 conditions. Then we check the supertranslation. Again, same thing, the rotator cuff tear model, of course, supertranslation increase, and it's the same as my previous studies. Thin fascia lata SCR decrease supertranslation, but still higher than intact. But if you sandwich suture patch, even thin fascia lata, but supertranslation almost same as intact. And also, we check the range of motion to check the stiff shoulder or not after surgery. And because the suture patch, a very stiff material, so it may cause a stiff shoulder after surgery. Then we check the range of motion. It's an internal total rotational range of motion, internal external rotation. So intact 122 and the rotator cuff tear model, of course, increase because the supersize nothing. And it's a SCR using thin fascia lata 128 decrease, but still higher than intact. And suture patch reinforcement, suture patch with thin fascia lata, it's the same as without suture patch. So from this result, I can say the suture patch does not cause stiff shoulder. So you can use it very safely. And again, the just sandwich like this, and I can show how to make it later, but I can say suture patch makes the your clinical outcome is better, much better, I think, better than before, I think. And this is a clinical outcome. I started the suture patch March 2024, so it means almost 2 years. And then we have 92 cases in this study, and the graft tear rate only 22%. Yeah, and this is the MRI. 1 year after surgery, it's hard to see where is the suture patch actually, and it's incorporated. So the looks like normal tendon tissue, but this is a suture patch and fascial graft. So I really recommend suture patch to use to get a good outcome. So this is my first talk here, and any question?
Would you prefer to put the suture patch in between, like a sandwich?
When?
Why?
Yeah, why?
Or not on the top?
Yeah. First, good question. Actually, first I worry about the suture patch outside of the graft may cause the subarachnoid impingement. So that's why I studied the sandwich. But now I'm using the suture patch with the biceps, the cuffment, biceps, the graft. That case here, repair the rotator cuff tendon, biceps, and the suture patch. So suture patch, actually outside of the graft. But already 1 year, maybe 10 cases, but MRI, no inflammation and no ablation and no subsequent impingement, pain. So even outside should be okay. But again, for the regular SCR, I worry about some impingement or any problem. So that's why sandwich. Yeah.
I'm using suture patch, and I prefer to put it on top.
Okay.
Because I believe that the suture patch protect the fusion against.
So far in my experience, no problem. So maybe how about your result? It's no problem.
I'm using suture patch recently.
Oh, okay. Yeah, please let me know there later in how your patient. But in my experience now, already 10 cases, the outside of the graft, but no problem. So should be okay. Yeah.
If you have a chronic superior elevation, do you release the inferior capsule to take the pressure off your graft?
Yeah, good question. Actually, Dr. John Kelly, he told me that if you release the inferior capsule, much better the super stability. So now I'm doing. So maybe the biomechanically it's correct. But If the patient does not have the stiff shoulder, it's not necessary. But if the patient has stiff shoulder before surgery, I recommend to release. Yeah.
To his point, I used a polyester patch on top of rotator cuff.
Okay.
To present some of that tomorrow.
Okay.
And it's amazing what no stiffness.
Yeah.
Implants look great.
Oh, you do.
Patients have no pain.
Oh, yeah.
I don't know why. Maybe it's the restoring of the
Restore stability, that's why, I guess. Yeah.
It's so much better.
Yeah.
Is that the speed patch?
Yes. Yeah.
John's
What is
gonna
this
give a
patch?
presentation on
What?
it tomorrow.
Who makes this patch?
Yeah, actually, I and Arthrex company.
So Arthrex?
Arthrex and my idea 10 years ago, and finally FDA approved. So this year in US, maybe you can use now, but in Japan 2 years ago. So we started already.
It is available?
Polyethylene or?
Polyester, yeah,
Polyester.
yeah, polyester, yeah, it's the
Only
same,
different material.
yeah.
It's available in the US.
It is.
Yeah.
Since November, I've been using it since November.
Who? What company?
Arthrex.
Arthrex, yes.
Yeah, Keith Taylor's here, you can talk to him
Yeah.
about it.
Cool.
Yeah, I really recommend, yeah. Biomechanically, clinically, so far, very good result, yes.
I'll show you a great way to fix this graft tomorrow.
Yeah, and maybe afternoon, yeah, maybe we can show, right?
Well, his demo is gonna be, I saw your video.
Oh,
Not your
okay.
video, but I saw the product video. It's a unique device to fix it.
Oh, okay, yeah, thank you, yeah.
John's talking
Peter,
to
is
the
it-
Tomorrow.
That technology with this technique.
Yeah.
Okay,
It
okay.
reminded me of
That should be
tattoo
good, yeah.
technology.
Okay, yeah, we can combine, yes. Any question to?
Do you have a landmark for the posterior cable? Is that characterized?
Actually, posterior cable, not anterior cable, posterior cable. Yeah, so the SCR, actually, we reconstruct the anterior posterior both cable, actually. Yeah, so that's why they're good result. Yeah, but yeah, if the anterior cable is intact, maybe you can make a posterior cable like a partial repair, then good outcome. Yeah.
But do you have a landmark?
So
Where do you
landmark?
How do you know where?
Oh, yeah.
That's C4 on
The
the
C4 was on your diagram.
Right.
It was broad.
which is really at the turn of the back, it's really like 2 centimeters behind the biceps.
Yeah, 2 or 3, or
That's
yeah.
That's a very broad
Yeah,
zone.
just insertion of the infra, I think. Yeah, just behind the supra. Yeah.
Yeah, but it's really that far back. It's,
What do you do with the cuff? If you go back to your last slide,
Mm-hmm.
that tendon looks like it's
Yeah.
beautifully attached to this graft.
Right.
It almost
Yeah,
looks
I try to put the graft under the tendon like this.
Okay.
Yeah. So yes, it's here, but look, and the MRI looks like the normal tendon after surgery. Yeah.
But you don't switch the remaining tendon to the graft.
Yes, sometimes, yeah, we suture maybe just 1 suture or 2 suture to the supra and the graft. Yeah, but some patient does not have tendon tissue at all. That case, yeah, just SCR but posterior side suture is necessary. Yeah, infra and graft or teres minor graft. Yeah.
But that pre-op, look at, there's like, 15, 20 millimeters. of
Yeah,
tendon
yeah,
on the front.
right.
You pull that up and over, and
Yeah.
you get this.
Right.
I love it.
Yeah.
the fascia lata, at least in my experience, echoes what the biology studies have shown with rabbits, which is it somehow enhances the healing ability of the cuff. I don't know if that's because of the graft itself or because it unloads the tendon, so the tendon is not under undue stress, but it seems to heal to the graft very readily.
There's
So
blood
there's
supply in the tendon.
There's animal data showing.
Yes.
So if you had a thick and stiff skin dermal allograft that was 8 millimeters with a patch in it,
I don't know about
it
that.
still may not heal.
Yeah, exactly.
Because there's evidence of the
Yeah,
biology.
and those articles are included in your USB. So I've got those articles included in the USB, because I thought so for me, the rabbit studies that you guys did, Taro, were very, very informative about what I was seeing with patients' recovery, because the collagen organizes starting around week 16 to 24 into a much more tendon-like structure. And that's when we were seeing patients starting to recover, feel good enough to raise their arm actively. And so our therapists, I talked about it, and we had modified our rehab to go much slower in the beginning to allow the graft to start to gain strength and thickness. And then once we see the 3-month MRI where we have this sufficient density thickness and we don't see an interruption, we then kick up the physical therapy and let them start doing a lot more at that point. We thought the biology, though, study matched what we were seeing clinically.
Okay.
Process question about, you did 3-month MRIs and 1-year MRIs.
3-month and 6-month MRIs.
6 month, how do you get that funded, approved? It's all part of the research, because I try to get a 1-year MRI, even on a workers' comp, and they're like, no, why? You don't need it, they're doing great.
I guess I'm part salesman, I don't know.
But is all of your patients part of a research study that is a funded